Hearing none, we're going to record so we can share with our colleagues. What Claire and I have decided to do this year is have our interest group meetings on 4th Thursdays at noon. And she and I are going to be alternating leading the sessions. And this is our kickoff for the year. And we're focusing today on social emergency medicine. And I think what would be great to do, I'm sure we all want to do introductions and say hi, but I'm thinking we could save that towards the end because I want to make sure that we have time for Hemel to give a presentation, which is going to be about 30 to 35 minutes on the work that he's been doing. And then we're going to have a panel discussion with Shannon and Dennis joining Hemel to have a conversation. I think it would be great to just dive right in and have Hemel. I'd love to go around and hear what everyone's doing, but if Hemel, you could take it away, that would be awesome. Maybe, there you go.
Yeah, sorry, I'm just trying to unmute myself. All right, cool. Thanks, Mimi, and thanks, Claire, for having me. And I'm excited about having space to talk about social emergency medicine. I am going to generally introduce the concept of social emergency medicine and primarily spend some time sharing examples from San Francisco. And I'm also very excited to learn from Dennis and Shannon and you all. So briefly, social emergency medicine incorporates consideration of patients' social needs and larger structural context into the practice of emergency care and related research. And in doing that, the field basically explores the interplay of social forces and the emergency care system as they influence both the well-being of individual patients, but also impact the broader community. There's recognition that health is more than healthcare, right? And if we're not focusing on those underlying social, environmental, economic, behavioral factors driving health, we're really missing opportunities to advance our patients' health and our community's health. So putting my sort of like ED doc hat on, the typical fix of, prescriptions and follow-up visits are not going to be enough for many of our patients. I can keep on caring for the patient who comes in with COPD exacerbations, but until I can help that patient afford their medications, have transportation to their outpatient appointments, live in a smoke-free home, I'm not going to really help that patient's overall health. So, these concepts are not new, but they were really formalized in emergency medicine, honestly, in the past 5 to 10 years or so. They've been championed by people like Harrison Alter, who's an ED doc in Alameda Health, and people like Dennis and Shannon. Dennis is the president of our professional society's section on social emergency medicine. And through sort of, their work and many, many others, this has actually become the fastest growing discipline within emergency medicine. And it's driven by a lot of interest in the future generations. So students, trainees, and that is who is going into emergency medicine right now. It's a really, really neat time to be in the field. I put a little picture of the inaugural textbook that was published this year. So the field in emergency medicine is brand new, even though the concepts have been in existence for quite some time. So Mimi asked me to share a little bit about sort of my work in San Francisco. And I thought I'd just start with recognizing a couple of my professional roles. So I'm an emergency physician at CSFG in San Francisco. I trained as a health services researcher, and most of my time is spent on operations in a local safety net health system. And I feel really sort of lucky to have a career that balances clinical work, local health systems improvement, and research to disseminate sort of learnings. And the combination of those sort of three roles are, I feel like they're really synergistic and they support my own wellness and joy in medicine. So I'm going to talk a little bit about each of these roles, and I'll just start with like at the clinical level in the ED. For me, that means really honing in on patients' self-identified needs. And so if I am caring for a patient and they say what they most need help with, in that moment is food or housing or whatever, I'm going to commit myself, even as their ED doc, to working with them on those and separately try to push the health delivery system to better address those type of needs. Today, I'm going to go through a couple sort of research and operations examples that fit within the social EM domain, but just highlight when you hear from Shannon and Dennis, you're going to realize like this domain is pretty broad, and it essentially includes the intersection of the acute care system with society. So it can mean many different things. This is my version of what it means sort of for me. And the work I'll talk about today is obviously a reflection of many, many other people, including many people at CHCF, which has been neat. So I'll start in 2015, largely as a result of some luck and sort of lucking into the mentorship of Alice Chen, who I think several of you know as a really inspiring CHCF alum. I was plugged in at an early point into the San Francisco Department of Public Health, their sort of complex care analytics group. And I got to work in sort of helping expand and build the system called the Coordinated Care Management System, or CCMS, which was sort of created through the vision of Maria X. Martinez. And briefly, CCMS is a DPH data system that integrates at the client level information about patients' physical health, mental health, substance use, and social information, with a focus on clients that the DPH serves, and with a particular focus on homelessness. And you can see through the schematic some of the information that goes into CCMS. So it includes some like traditional medical information, like medical diagnoses, but it also includes information about sort of housing status, engagement with case management, interactions with the criminal justice system. So it's pretty unique. I joined, while this project had been going on for quite a while. And my role was primarily to understand sort of what the limitations of a system like this were, where we could learn, where we could do better and make it actionable at the patient level, where we could use data systems like this to understand questions at the population level. So, it was a neat time. I got a chance to help integrate this data with sort of traditional sources like Medicaid claims data, as well as to advance, sort of our appreciation for our patients' lives through, for example, integration with the criminal justice system and working with the San Francisco DA's office and the sheriff's office to link sort of medical information. We got to see, unique users use this data more at both the client level when they're caring for patients, but also in 2018, as a result of the whole person care pilots, got to use this system for the first time for really traditional program evaluation research. So I'm going to sort of start there and give you an example of a very simple project where, this was the first project that came out of this data system. And we were essentially looking at people who use the ED frequently and comparing them to people who don't across all of their non-medical sort of utilization. And this was interesting to me because I'm an ED doc, but it was also interesting to me because there's this pervasive message within emergency medicine and sort of across policy to basically get people out of the ED. ED use is seen as a problem. And yet from my clinical experience, we have this patient population that's coming to us very frequently, and we're not really set up to meet the needs in the current state. So this is a very simple sort of analysis, but essentially we took Medicaid beneficiaries in San Francisco. We looked at people's ED use, and then we looked at where else they were touching our system. This graphic is very simple and essentially shows that people who use the ED a lot are also accessing mental health services in San Francisco. They're also accessing substance use disorder related services in San Francisco. And there's sort of a dose response sort of curve. People who are using the ED a lot are using a lot of these other services. When we looked at this in more granular detail, I just want to portray that people who use the ED a lot are using every other city service. They are touching our social and medical and mental health services multifold. So that means more primary care, more specialty care, more likely to get admitted, more likely to be at respite, more likely to access outpatient mental health services, more likely to access crisis mental health services, more likely to be using the detox centers, the sobering center, more interaction with the criminal justice system, more interaction with services arranged for people experiencing homelessness. So, I'm sure this is not surprising, but basically focusing only on EDUs really provides this limited view of patients' lives and where they are accessing health and social services, and really speaks to the urgent need for, care coordination and communication. And when we did some more advanced sort of modeling and statistics, when we looked at things that were independently associated with frequent EDUs, so this is people who are using the ED over 4 times a year, attributes like homelessness and comorbidities like alcohol use disorder are the strongest sort of factors associated with high EDUs. And this resonates, with my own clinical experience, but again, reinforce the notion that like the ED and the acute care system is not set up to meet the needs of many of our patients. So this type of analytic work sort of pushed me and others, like Dennis and Shannon, to think about like, what can we do better here in our local health systems to really support sort of patients like this. I mentioned that I work at ZSFG. Just as a quick overview, we're a level 1 trauma center. We're the public county hospital in San Francisco, and about 2/3 of our patients are Medicaid beneficiaries. We're a teaching institution, and we were trying to think of like, what can we do better here to start? And Mimi sent out a little blog post that sure captured some of this, but we tried to create this program called Social Medicine for patients like Jane. And I'll mention that this was my CHIP project was focused on this. So Jane, when we met her, which was pretty early on in the formation of this program, was an elderly woman who had been essentially living on the street for many, many years. She essentially had been living on public transportation, taking the Pittsburgh Bay Point BART line back and forth throughout the day. And she was frequently incontinent of urine, and, bystanders who were concerned about her would call the BART police, and the BART police would come and collect her and essentially bring her to an ED. She had over 60 ED visits at the General alone. She had over 150 ED visits at Bay Area EDs in the year prior to us meeting with her. And that day, we were lucky enough to be involved, and our patient navigator and one of the clinicians on our team basically sat with Jane. And again, one of my sort of driving philosophies is really understand what patients' self-identified needs are. So we asked her what were the things that were bothering her, and she said that she was hungry. She hadn't had a chance to eat regularly. She said that her bottom was hurting her. She had developed wounds from sitting in soiled clothes repeatedly and not having access to clean clothes in the shower. She said that she was afraid that people were going to take her belongings. She had all of her life's belongings in sort of frayed bags attached to her wheelchair. And so we did some small things. We got her a meal. We were able to get her clean clothes. We were able to reassure her that no one was going to take her belongings, and we brought her some new bags to sort of better upkeep her materials. And, through the course of a 6-hour ED visit, we tried to slowly build rapport with her, and, and we tried to introduce the idea of moving indoors from the ED. And she was hesitant about this, honestly. But she was willing to meet with one of our community partners that specializes in care transitions and homelessness. So we had a case manager come to the ED and meet with her, and they bonded over a shared appreciation for clothing. It turns out Jane had been a stylist earlier in her life. And again, with sort of little more than sort of these types of just basic, helping people meet their basic needs, she was willing to trial moving indoors from the ED that day. We were able to get a place at a psychiatric respite facility. And over the next 6 months, we were able to work as a health system to get her an ID, to get her on entitlements, to get her to join a community, to have regular access to food and shelter, to help her wounds, her sacral wounds heal, and eventually to move into long-term housing. And in the year following this visit, she had only 2 ED visits, and they were both for UTIs. This is a powerful story, and this is not all stories on our team. I also just want to portray like something more can be done than what our current state is. So my approach and our approach at the General to health systems change has really been based in sort of lean performance improvement. And you're going to see some of that coming through in the next couple of projects. But for me, like some lean sort of triggers like either strong, positive or strong negative sort of relationship in my experience. And I just want to, for me to simplify it, like the driving tenets are really using the scientific process, using data to drive improvement, and then sort of putting patients and staff at the middle of what you do, and being persistent and understanding the work and recognizing that staff who are facing these problems have good ideas. And so these next couple of projects are based in those type of philosophies. So I'm not going to go through this, but this was our sort of project plan, or our A3 for the social medicine program. And this is more just to say that before we did anything, we spent 6 months really doing deep thinking, doing stakeholder interviews, meeting with patients, meeting with, ED clinicians, meeting with social workers, meeting with community programs to really understand sort of why patients with low medical acuity but high social complexity end up sort of hospitalized, even though the hospital might not be the right intervention. And the hospital is not set up to meet some of what the needs are. So the initial concept was for patients like Jane, for people like Mr. D. So this is a simplified, version, but someone who comes in for a soft tissue infection, but who's also experiencing homelessness and is also struggling with addiction and wants help with those. And the initial concept in our thinking has progressed since this time, but was basically to help Mr. D and wrap Mr. D around with services from a multidisciplinary standpoint, so that we can maybe give Mr. D, free medications and lower the barrier in getting his antibiotics, and maybe, have a warm handoff to an outpatient team that will do a wellness check, and maybe help Mr. D get transitional housing from the ED, and maybe start medications for opiate use disorder directly from the ED. And that's something that in the last 5 years has dramatically changed that last rung. But the hope was that, in emergency medicine, I think it's really interesting that we have these amazing resources and this amazing, like for the patient with a car accident, we have like this amazing dance of the trauma surgeon and the ED doc and the pharmacist and the respiratory therapist and the social worker, and they descend on that patient. But we don't have anything as systematic and as structured for the majority of our patients who are like Mr. D or like Jane. And so the hope was that we could do two things. We could sort of, for patients with high social complexity but low medical acuity, provide a safe option that was community-based for patients, and that we could really increase multidisciplinary teamwork in the ED for patients like this. And so that meant, integrating people and work and disciplines that hadn't historically worked as a unit. So people in the ED, think people like social workers and nurses and pharmacists, but also people outside the hospital. At the hospital, like I'm not the expert in homelessness or in addiction care, but there are many people in San Francisco County who are experts on that and know the resources and know how to navigate the system. And so we sort of set off to do several small tests of change. The only new entity in this picture was really a patient navigator. So again, at the time, community health navigators or patient navigators or patient care coordinators, they weren't commonly used in ED settings. That's again starting to change. But we set off with multiple different sort of PDSAs, Plan, Do, Study, Act cycles. I've showed you some data here for 2 of them. So we developed a formal consult service. So, similar to like orthopedics, if someone has a broken arm, but for patients like Mr. D or like Jane, where we have a multidisciplinary team sort of work in a concerted fashion in service to them. And then other things that I've sort of alluded to, like very simple ideas. We termed it the Meds in Hand program. That's essentially like for Mr. D, like instead of asking him to take a bus or 2 buses to a pharmacy, to go pay out of pocket for meds, using money he may not have, and then to find a place to keep his leg up to get over his wound, it's like, can we just give him the Bactrim in his hand, his week prescription free of charge, walking out the door? Very, very simple idea, not going to revolutionize something, but just to lower sort of the burden a little bit. We have 20 plus different sort of PDSAs or improvement efforts going on, and they range from, things that I've mentioned in terms of like that simple meds in hand project to social needs screening to helping people on the path towards permanent supportive housing. We, at a high level, some of the, results have been in the first couple of years of the program, first 3 to 4 years of the program, we were able to serve over 6,000 clients. We were able to provide an alternative to the hospital for about 1,000 clients. We were able to provide a couple thousand clients free medications. And again, just to highlight, like the cost of that meds in hand program was $4,000 for those 2,000 patients. One night in the hospital ends up being, about, $2,000 to $3,000. And so there's some stuff that's like, just seems to be a no-brainer. We looked at some balance measures, things that we didn't want to create inadvertent unintended consequences. And so our work has not been correlated with increased length of stay in the ED. It's been correlated with reduced sort of revisit rates, reduced non-acute inpatient days. And for some of our clients, we've had transformative outcomes like helping people towards housing. And obviously it's not a high volume, but that's sort of like that's the best outcome. People who are smarter and more talented in our team now have created, more technologically savvy things. And so there's a website if people are interested in learning more. We were able to write about this in JAMA, and there's a 20 or 30-minute podcast that goes into more detail about the team and the approach that may be of interest to some of you. So with that, I'm going to fast forward a little bit and this is a sort of like final project, talk about COVID. And I want you to sort of remember what it was like in February and March and April of 2020, when we were in serious learning phase. But again, this project comes from, experience working as a clinician in the ED and thinking about how are we better serving sort of some of our patients. At that time, unsurprisingly, I was discharging people experiencing homelessness with, COVID symptoms and saying, good luck, try not to interact with anyone. Or I was admitting them to the hospital saying like, I know you're not that sick, but I don't feel safe with you, being discharged yourself, and I don't want to make this pandemic worse. And neither of those options are ideal. If you remember from sort of China and from Italy and from New York City, excess mortality from COVID prior to vaccines was really linked to when health systems were overwhelmed. So when there were no inpatient beds, no ICU beds. And I was personally worried about, we have this public health crisis with COVID, and then we have another public health crisis of homelessness. And this is just a bad sort of combination. And so, we spent a lot of time thinking about the hospital system. What's our sort of like, how can we approach better care coordination for people experiencing homelessness with COVID? And again, we use really basic performance improvement techniques. So this is a picture of like standard work, it's called, and it's just, how do we get people to do things the same way and have a standard process, especially for something that's new? So we were trying to work closely with San Francisco HSH, the Departments of Homelessness and Supportive Housing, and Human Services Agency to stand up isolation and quarantine hotels. And then how could we maintain hospital capacity? And so we worked with multiple different teams to basically figure out a logical system to support patients getting to hotels, basically from the hospital. So this project is just about how we did process improvement in that. This was, again, March 2020. So the rows on this table are the first couple of months of the pandemic. And we essentially looked at just how many patients could we successfully get from the hospital to isolation and quarantine hotels. And this is, again, for people experiencing homelessness with COVID. And you can see that we were pretty unsuccessful up front, like 2/3 of our patients were not getting there. And then we did a bunch of improvement, and then we tried to, reduce that number. But I want to go through our process. So the first step was really like understanding this basic data and then asking why. Why were patients not getting there? And this is another very commonly used technique called a Pareto chart. And it helps you really see like where the biggest bang for the buck is. You can't do everything, right? So where do you focus on the biggest barriers? And we learned by asking why that basically the isolation and quarantine hotels were denying most of our patients. So then again, we asked why. Turns out at that time, the INQ hotels were not set up to meet patients' needs with substance use disorders or with mental illness, or who needed ADL support, or who had family needs and childcare needs. So taking very, very basic data like this, and then feeding that back to our team and thinking about, as a city, what can we do to better sort of meet the needs of our patients? So this gets at, work that is really near and dear to Shannon's heart, I think, but thinking about how do we improve harm reduction services in our community. We were really fortunate as a healthcare system to work with HSH, to work with HSA, to work with people, like Shannon and others to think about, can we set up a managed alcohol program? Over time, this has meant multiple harm reduction services in hotels. So things like wellness checks, meal deliveries, telemedicine for addiction care, delivering medications for opiate use disorder, and offering counseling for stimulant use disorder that are based in the hotels, offering laundry and storage for belonging. So really, again, trying to meet patients' basic needs. These graphs show sort of like basic data. The top graph shows the number of clients who went from the hospital successfully to the hotels in the first 10 weeks of the pandemic. And I just want to highlight that within 2 weeks of the first case of COVID in San Francisco, the hospital was sending 20 patients a week to the hotel. So really high volumes that otherwise were patients who were hospitalized, taking up inpatient beds. The bottom graph stratifies that data by where on campus, what type of clinical facility. So the ED, urgent care, the inpatient units, and primary care. And again, you can see that beige line, let's see right here. Every single patient in the beginning was from an inpatient bed. And that number decreased over time because we were able to get people there earlier in their stay. So not need to reuse those inpatient beds. And again, I want you to remember like that inpatient capacity, that was what was driving this, and the concern that maybe we would be, have the same experience as Italy and China and New York City. And so we were lucky in San Francisco not to have that experience, but this was sort of forward thinking. This was work that we did with many CHCF alums. Alice Mohemian was helped direct the INQ hotels. Navina Boba sponsored a lot of this work. So we're really proud to work with the CHCF community on this. So that's sort of like a high level, social, like example of social emergency medicine projects. Some of the work that our teams are doing now, we're looking at shelter in place hotels, the impact on high users. We're looking at San Francisco's Housing First initiatives called the Shared Priority Pilot that were meant for people with chronic homelessness, serious mental illness, and substance use disorders and psychoses, and looking at housing retention. We're just thinking about ways to use the ED as an opportunity. So again, during COVID, that's meant like, can we vaccinate people when they're in the ED who may not have access to vaccines elsewhere? That will give you a breath, and I think Dennis and Shannon will be able to share sort of beyond that. I like to end just to acknowledge that a lot of this work is downstream. My work as an ED doc is downstream at the clinical point of care. The social medicine program, maybe a little bit more upstream, like looking at individual clients and meeting their health-related social needs. But none of the work I talked about today really is about sort of changing our community infrastructure. And sometimes social determinants of health gets conflated with individual social needs. And I think it's important just to recognize there's still a lot of opportunity with this work and within the field of social emergency medicine to really move upstream and to think about how we change our community's access to affordable housing, affordable food, poverty reduction. And that will be sort of what really drives and moves the needle on this. With that, wanted to appreciate you all for your time and Mimi and Claire for having me. And I am, happy to turn it over to Dennis and Shannon.
Thank you so much, Hemel. And I just want to say that I put in the chat when our next meetings are, so you can note those down, and to let you know that we're going to be tapping others of you to give presentations as we move through our year. So this is an informal group. I mean, we're a group of colleagues. And so what I wanted to do was really to open it up and to say that we have Dennis and Shannon as panelists. And so perhaps we could start with Dennis, and then Shannon just give a brief introduction of your work, and then we'll just open it up to questions for the group.
Totally. Thank you for having me. Dennis Shea, current CHCF fellow, Chief Medical Officer here at Contra Costa Health Plan, and working a lot on social determinants of health through CalAIM, enhanced care management, community supports, as well as other initiatives. And I think probably the one comment I'll make is just reflecting on what Hemel showed in the very beginning, right? I think even though this talk is titled Social Emergency Medicine, as Hemel showed via the data, right? These are not patients or problems unique to the emergency department, right? These patients touch many other systems based on the data and graph that you showed, Hemel. And I think sort of this brings up the point of, why am I at a health plan? The reason I came to the health plan was, I think, in large part recognizing that and realizing that we do have to take a systems approach. The emergency department doesn't have to go at it alone, nor should it go at it alone. It's really a shared problem. And if we leverage all the good work, especially with CalAIM, all the funding coming through, we can really make some impact on this problem beyond sort of any one group or any one clinical department feeling frustrated. So I'll turn it over to Sarah.
Hi, I'm Shannon Smith-Bernardin, and was actually in the cohort 18 with both Mimi and Hemel recently. So my work, I'm a registered nurse by trade, and I mostly focus on healthcare interventions for folks who are experiencing homelessness. And a lot of my work is around unsheltered folks. And so going out into encampments with street nursing, street medicine, is a lot of work I do now. And then primarily, which is one of the things I'm here about, are sobering centers. So looking at public intoxication and alternatives for care. Typically, when someone's intoxicated in public, they're brought either to the emergency department or to jail, unless the community has a sobering center. And a sobering center is different than social detox, medical detox, sober living, et cetera. So sobering centers are basically short-term, 2 hours all the way up to 12 to 24-hour stays for an individual who's intoxicated, just to get reconnected to services. And as Hemel mentioned earlier in his talk, if you look at the individuals coming into the ED, all the other complications that they have going on, the other comorbidities, et cetera. We had done a study with UCSF, and I ran a nonprofit related to this. And we looked at everyone who came to the sobering center for an entire year and everything they had going on with them. And the folks who came in one time had a serious medical problems, et cetera, that similar to the rest of the general population, a little bit more liver disease, which most folks would say is not unexpected. But especially started looking at individuals who came to the sobering center who'd visited more than 5 times. So 5 and more times during the year. 38% had hypertension, 40% had histories of psychosis, almost 60% had histories of depression. And these are diagnoses by a physician, not just a client self-report. And so then people who are ill with these also overlap a lot with the substance use, mental health, and then the amount of visiting that they've done throughout the city using that same CCMS database with, shout out to Maria X. Martinez, of course, and all the work she had done for this, for San Francisco. And it's amazing what we can look at now for an individual who comes and touches anything in San Francisco. We can really see where they've been And based on that information, and ideally working with the individual, what do they want at the moment? What do they need? Figuring it out. We do the same kind of thing in sobering, same kind of thing in street medicine, street health outreach. And I'll kind of stop there. I also do stuff with medical respite, but that's been a couple of years at this point. So open to any questions, and also do a lot of health policy. So that's always a keen interest, especially when it comes to things like, let's just make alcohol more expensive. Less people will drink it. Ooh, less people in housing will drink it. However, people who don't have housing, who can't afford it, will end up buying stuff that is non-beverage alcohol, mouthwash, hairspray, etc. So it's like we have to be able to weigh kind of who it impacts the most. And so I'll stop there.
Yeah. Thank you, Shannon. And I put in the chat our future sessions coming up, and Shannon has kindly agreed to lead our October session, which will focus for Thursday on sobering. And to keep us organized, how about if you raise hands and I'll call on you? If anyone has any questions to ask Hemel or our panelists, or any thoughts to share? Or go ahead, Alan.
I'm an old guy, as you can see. And in about 10, 15 years ago, I got a chance to visit San Antonio, who have a very similar story to this. And what they ended up realizing was that the sheriff's department, who were bringing the people into the ED over and over and over again, and it impacted the ED in terms of, disposition. So they had people on gurneys for 2 days at a time, with the deputy sheriff getting overtime watching the person before they got cleared to be taken to jail. And it was $4 million budget a year. And what they did was the ED, head of the ED went to the sheriff's department and said, how much does that cost you? And the answer was 4 million. And he said, give us 2 million and we'll build. And there's a lot more open land in San Antonio than San Francisco. And I trained at San Francisco General, so I know that place well. They built a center that does every single thing that you're doing, but in one building. That started with a safe place to sleep at night outdoors, and ended up with job training. They had a sobering center. They had a detox center. That was a 30-day thing. They had primary care built into it. They spayed and neutered and had veterinary services for people's pets. Oh. And they lowered, the last time I talked to the guy who started this, which was about 5 years ago, and it's a man named Leroy Evans, would be a wonderful person to invite. He's a real character. They've lowered homelessness by 80% in San Antonio over 15 years. And here, geographically, you can't have it right next to the ED like they did, but you've done the same thing by linking all these services. What my specific question is around. It sounds like the primary care is the in-shelter care and the street medicine care, and how important is continuity of care? And not that it has to be through the physician by any means, but what relationship stuff, is that what this is really about at the core, is building relationships with individuals that you can sustain? Or is that not important?
Well, so yeah, really important questions, and a couple in there. I would say that one thing that has been challenging, oops, am I frozen?
No.
No, okay. Is that, originally, this has been, it's an episodic model for people who are in crisis, who are coming to our ED. And there are definitely clients that we are their main, team of contact on, and they're in the ED sort of more than anywhere else. One thing that we've sort of tried to pride ourselves on is really getting a sense of what is the landscape? What's the ecosystem of clinicians serving these patients? And how do we collectively work with them? And so yeah, we haven't taken on the role of primary care, but we may help push their housing status forward. And then we may interface with their community teams and just say, hey, here's our care plan. How does this, have a synergistic care plan? I think it's a good question. I do think continuity and trust are a really big part of this. And so without those pieces, I think people have a lot of trauma, both at the patient level and the sort of clinician level for the clients we're talking about. And so it is about that relationship and trust building. And we try to do what we can. And historically in our current setup, like the core social medicine team is largely ED based with team members elsewhere who are following patients in the community. Long-term vision would be, it would be great to move away from that. And so we're trying to scale this work on the inpatient side. And we've had some success, but one missing piece again is hospital-based folks are not following folks into the community and sort of doing wellness checks and checking to make sure that this, this respite facility is working out. And we need that component. We have historically had community partners that have been able to do that, but there's been some resource reshuffling that Claire and I talk about on a regular basis. But I think that's something that we are looking forward to and need.
The deputy sheriff took us around who had quit the sheriff's department and worked for the center, which is called the Center for Healthcare Services. What his description of the program was from a Texas point of view was, we're turning bums into taxpayers, is what he told me. And that's, it's funny, it's also pathetic, but that's the next step of the journey, and rather than just reducing episodes. I don't know, I would urge everybody to check into the San Antonio program because it's alive and well in the reddest of red states. So.
Cool. I mean, that's awesome to hear. And I think it gets to the point of like through across medicine and healthcare, there are best practices, and it's not like, you want to learn from each other and help advance the learning. And I just wanted to add that like the episodes, I think I mentioned this a little bit, but like, I don't know if patients care about how many ED visits they have. And so that's not like a really patient relevant metric to follow. And so like, I think moving the field towards like, what is relevant to patients? What do they care about? When we ask that question, it's like food and it's housing, and so like really focusing and incentivizing, and this is where I'm looking at Dennis, incentivizing healthcare to move in that direction, I think is where we need.
Are you talking about a triage social worker instead? Hi, I'm Susan. I'm a senior medical director at LA Care, and I've been an emergency physician for 30 years. And I would say Dr. Louis Goldfrank back in the 80s started social medicine when we used to have to go out and pull homeless people off the street and give them one of our horrible cheese sandwiches, give them clothes and put them in obs. And then we had to let them go before they started to withdraw. But I'm excited to see what you're doing. I think just a couple things come across. You may want to talk to some, San Francisco is a tight little community, and we have a beast down here in LA. And so I'm kind of like sitting right on the fence because I love what you're saying, but I also know from a health plan, there are real issues, and I don't know what CalAIM is going to really, I'm not sure how much it can address it with the reentry population, all that aside. But I know one thing about emergency physicians, and there's a split with this of what they're willing to do. And so I feel like we've been very successful with CHWs and having that kind of team be the front line for members wherever they are. But my other issue is down here. Have you ever heard of Mark Eckstein? I've worked with him forever at county, and he's the head of EMS. And so what they were trying to do is do this team out in the community, instead of transporting every single member or person, there's not member, that was a patient, person, human. What they would do is, you may want to contact him. They are looking at ways they can intervene out in the field. And that might be a nice kind of partnership with your pre-hospital system. And then I would love to see that there's some, another one of these ridiculously rich people who wanted to buy this huge building complex down in LA and create a campus. which is hopefully one way. This is what I foresee, that we can have a campus where we can take these poor people and take care of them in a way that's meaningful. I'm interested in older adults, and I'm just seeing there's a tremendous amount of older adults on the street all alone. And so anyways, I like what you're doing. I just think it requires more partnership with your local health plan, because I would be interested, hint, hint. And then also pre-hospital would be really critical, because they're really taking a lot of the hit. I mean, during COVID, as you know, it was a nightmare. Ambulances were waiting. We had people waiting 4 hours at LA County to get into the ED. So just another food for thought, but thank you. It's interesting stuff. And I'm kind of happy to see that we finally emerged. I thought palliative care was a lukewarm uptake, which I was part of, but this is really important what you're doing.
And I'll give a shout out because we do use up here in San Francisco the community paramedicine team. And I actually worked with Mark Eckstein when I was down in LA, also at Housing for Health, when they created the sober unit. So down that brought folks into the sobering center there with Steve. Oh my God, I'm blanking on his last name because it was an S. But the team there that was doing that. We have the amazing community paramedicine team up in San Francisco that I know works a lot with the sobering center. Go ahead, Dennis.
So just a couple of thoughts. Thank you for raising the CHW point. So as those in California know, CHWs are now a covered benefit under Medi-Cal. And a few of us have been exploring, can we use that benefit in the emergency department and inpatient setting? I see nothing in the regs or the APL that prohibit it. So we're actually moving ahead with both CCRMC and John Muir to figure out how to make this work. So I think sort of addressing both of the points. And I think, you know, my impression for CalAIM, right? I know sort of CalAIM brings many reactions to many people, some positive, some not so much positive. But in my mind, you know, CalAIM is a reason I came to the health plan and is also my CHIP project, right? I think the big thing there is really what it purports to do under enhanced care management and community supports is really sort of taking Hemmel's model and replicating it everywhere, right? For the lack of a better way of looking at this, in both inpatient and outpatient setting. And I think, you know, whether or not that's successful is all of our responsibilities, right? Like in Contra Costa, I'm faced with a unique challenge where we have an integrated system, but my teams feel like the medical management is not part of their job. And we're really trying to get them there, right? Other places have different challenges, from contracting to payments to data sharing to other things, right? But I think the vision of CalAIM is exactly as Hemmel described, right? Having a team of multidisciplinary professionals who are addressing social needs, physical health, mental health, substance use needs, and really paying for it all, although we may say not paying enough, but at least starting a payment system in that it's a benefit, in that it is theoretically going to be ongoing and sustained. It is no longer a grant program. So I think there's a lot of promise there. And I think it's up to all of us to really take that and make it work in our local settings. And no, I do not work for DHCS.
Neither do I. And I think CalAIM also has a lot of really attractive elements.
So for those who haven't, looks like there's, I'm sorry, for those who haven't spoken up yet, do you have any questions for our panelists?
Well, I have, I guess, a follow-up with Susan. Is that the plan for St. Vincent's Hospital to be a center for I guess, all-inclusive center for homelessness and
I'm not sure. I don't know about St. Vincent's. Were you talking about the investment guy that wanted to put money?
Yeah, there was talk that they were going to utilize that, since that facility is not being utilized for that purpose. Also, I'm a veteran, and I do quite a bit of work with the West LA Veterans Homelessness Initiative. Spent a lot of time there. And I know that this falls into what they're trying to do, but I think you guys have streamlined it, and the approach, I think, is a little bit more all-inclusive, and I hope that we can get there hopefully sometime in the future. Thank you.
Thanks so much. I mean, for the folks down in Southern California, I mean,
Any
there are
other
a lot of
from other
people-
participants, any other thoughts?
I think
go ahead.
Mimi, you must be delayed because you keep coming in the middle of someone talking.
Take it away, folks. I just want to be sure.
Go ahead,
everyone-
Hemel.
So who's in the middle of things?
Claire, you go. Go ahead, Hemel.
I was just sorry. I was just mentioning that definitely folks in emergency medicine across LA County are thinking about these issues, and I think there's some really good work happening out of Harbor, I know, and I think there's a number of sort of like leaders in emergency medicine down there that are trying to push things forward.
Maybe they need you to come down and help. We're just gonna split you in pieces.
No, I'll just say that like these are really complex topics. So even like this work, I just feel like we're just scratching the surface. Like there's so much left on the table with what needs to happen. And so, don't get me wrong, like I feel like we're failing more than we're succeeding.
Yeah,
And
sure.
I think there's opportunities to continue to do better. And I think, and so I definitely hear it. LA, the scale is quite big, but the VA, like their approach to homelessness is better than anywhere else from a healthcare system standpoint, and how they sort of have supported reductions in veteran homelessness. I mean, it's something that we all could learn from.
Yes.
And Dennis still works at Harbor and is amazing. And so if anyone can do it, Dennis can do it.
I love that there's networking coming out of this session. We only have 6 minutes left. I want to be sure that anyone who hasn't spoken, if you have any thoughts you want to share. For you right now. And hearing none. Claire, I'm not sure if Claire had to drop off, but she is organizing the next session. So 4th Thursdays at noon through the year, we'll be continuing this. And please, this is open to all of our alum colleagues from the fellowship. Please let folks know, and we'll be meeting in person in Long Beach on the 15th. So I just want to say, Shannon, you know that program, don't you, in San Antonio pretty well. You've been there and you know the folks.
Yes, and one of my girlfriends is the medical director on the psychiatric side of things. And I visited Brian, who runs the Sobering Center. And their biggest issue that they have for many years is even the folks who couldn't fit in to like the various programs, which includes like respite, single transitional housing for moms and kids, et cetera, they had few hundred people sleeping on the front lawns inside. It's a gated, that's the thing, it's a gated community. And so folks from the outside can't come in, but they were letting many people just sleep there because they're like, well, it's safer inside than outside. So they struggled with that for many years. They still do, but it's pretty fabulous because you go to the Sobering Center and you walk down the hall and there's detox is literally 8 feet. Just take a left. The other cool thing that they have there are for the folks, and this is particularly because I know Los Angeles has this, the wall problem also, but police often have to take people to the emergency department to get medically cleared before they can take them to jail.
Right.
They actually have a room with a nurse practitioner there that they use from detox and sobering who's shared, and they do medical clearances at that Haven for Hope facility. So the police don't ever have to go to the emergency department. They go straight to Haven for Hope, get medically cleared. And if they obviously don't medically clear, then they'll have to go to the emergency department or get further care there and urgent care. So it's pretty fabulous program, yeah. And the one in LA, yes, there is one downtown that's being established with the big facility, Exodus Recovery, who leads a sobering center down there and has a psychiatric urgent care in Los Angeles and a few other many things. They are one of the main partners for it. Sorry, Dog City and Friends Dog. And so, yeah, that's it's a cool, like, I know like San Francisco's like compact, but we really don't play well together. Like there's good collaborate. We do not play. It's one of the main reasons I left San Francisco to go to Los Angeles was that, and they just don't play well. And that's my friend's dog howling at a ambulance going by, so I'm gonna mute myself.
Okay,
We've heard a lot today about Los Angeles and San Francisco. Any other bright spots across California that you're aware of in the social emergency medicine world? Oh, and we have the East Bay. But other than the greater San Francisco area and the Los Angeles area, any other bright spots in social emergency medicine?
I mean, so there, like across the country, there are so many examples of, groups doing amazing work. I mean, I can think of like many off the top of my head, but New York City is doing really impressive.
What about California?
Within California,
Yeah, so there's I forget his name. There's a ED doc with Vituity in Visalia that's doing a lot of good work.
Okay.
So that's one area. Ted Chan, the chair down at San Diego, has traditionally done a lot of work around Project 100 and sober, or Project 25, or Project, I think it was Project 25, around sort of housing, substance use. So those are two other spots that come to mind immediately in terms of other areas that have had some significant engagement with social emergency medicine.
And Dennis, in San Diego, is that which of the big hospitals is it affiliated with?
Ted Chan's the chair at UCSD,
UC
San Diego. Yeah.
Thank you.
What I would say is this is not just an urban problem. I live in Humboldt County, and they've had efforts like this. Funding has never persisted. CalAIM is a new moment, but it's, one thing I have a question about, and we have health people working for health plans on the call. Why isn't this going through public health, and why is it going through health plans instead? CalAIM is what I'm talking about. Is that the right pocket to start this with, or and what I'm interested in is sort of, and I'm working on is trying to bridge the gap between public health and healthcare. And it may be by taking the money away from healthcare first, and then going from that point on, because the public health is grossly underfunded to do any of this. So.
Yeah, and I think it's a good question, right? From my perspective, it's just sort of what are the things that have funding and sort of are incentivized to do this, right? If you think about who ultimately should be incentivized to decrease hospitalizations and ED visits, right, in the right way, although we know, as Hummel said earlier, it's a gross simplification, is whoever's financially at risk. So that's either the health plan or their delegate. Right? So it doesn't mean the health plan needs to do the work, right? In Contra Costa, the health plan is contracting with public health to do the work, right? So it is a way to fund sort of, I think it's a both and, taking from my CHCF training, right? Not a either or. So I think it's really, so that's sort of how I look at it. And I mean, it's just, where's the money coming from? It's coming from Medicaid, right? So it's easier to get Medicaid money to the right place through existing mechanisms than building a special project and driving everyone crazy with new and additional paperwork, is how I look at it.
No, that's a good point. The ERs around the state make $300 per ER visit, which is, it's not like I've been, the money is actually not, it doesn't hurt the health plan. It hurts the hospital, who loses money on every visit. So they're a source of interest in this. Sheriff's Department are a source of interest in it. We heard stories of overwhelmed facilities during COVID. That was a driver of temporary housing. So it takes, and in San Antonio, it was the Sheriff's Department. It takes creativity to figure out how to sustain these programs, and it always starts with who's getting hurt the most by what's currently happening.
Well, we've reached our top of the hour. This has been such a great conversation. Thank you, everybody. I feel like we could go for another hour, but we can't. So to be continued. Thanks so much for participating, and bravo.